You know, we trust doctors to solve the most incredible puzzles our bodies can throw at them. But what happens when the biggest clues are also the most misleading? We're about to explore the hidden mental traps that can lead even the most brilliant medical minds astray.
It all starts, as it so often does, with a patient. In this case, a woman whose conditions seem to have a really clear, sad, and pretty much unavoidable cause.
And that's the big question we're digging into. How could a diagnosis that made perfect sense on paper be so incredibly wrong? And what does that tell us about the tricky ways our own brains work?
Okay, so to really get this, we have to look at the case itself. It's a pretty powerful story about how a patient's own history can, well, it can kind of build a cage around a diagnosis, locking out every other possibility.
When you see the initial facts laid out, it's amazing how logical it all seems, right? You've got a patient with a history of brain cancer and radiation. She's got declining brain function. So the logical leap, it's got to be an incurable side effect of the treatment. This context creates a really powerful diagnostic frame. And this brings us to a huge idea in psychology, one that affects all of us, but in medicine, it can have life or death stakes. It's called the framing effect.
The official definition really says it all. The framing effect is what happens when we give way too much weight to the very first piece of information we get. For this patient, that frame was cancer. It was so big, so significant, that it just overshadowed everything else.
Now, this tendency gets a huge boost from a famous principle that doctors are taught to use every single day. You've probably heard of it, Occam's razor.
In medicine, Occam's razor basically means the simplest explanation is probably the right one. A new symptom pops up? Well, it's most likely related to a disease the patient already has. It's supposed to keep doctors from chasing rare diagnoses. But what if the rare thing is the real thing?
So this creates a fascinating tension in medicine. On one side, you've got Occam's razor, pushing for one single tidy diagnosis. But on the other, you've got this thing called Hickham's dictum, which is a great reminder that, hey, a patient can have as many diseases as they darn well please. That first diagnosis we saw, that was pure Occam's razor.
And this is the turning point, the moment everything flipped. That initial frame was solid, but then a new neurologist, just doing a routine strength test, felt something tiny and unexpected, a subtle cogwheeling in her limbs, a classic sign of Parkinsonism. All of a sudden, every old symptom got a new interpretation. Her slow speech wasn't just a brain injury side effect, it was a specific symptom. Her slow movement wasn't just general decline, it was another specific symptom. The frame was totally shattered, and a new, and most importantly, treatable diagnosis came into view: Parkinson's disease.
And the outcome here just shows you exactly what was at stake. I mean, this wasn't some minor correction for the textbooks. 1 week of treatment, 1 week, and the patient, who'd been in a wheelchair and could barely speak, was walking and talking again. A life was completely changed, just by overcoming one of these hidden mental traps.
So the framing effect is just the tip of the iceberg. Once you start looking for it, you realize a doctor's mind has to navigate a minefield of these biases that often just look like good, efficient thinking. Let's do a quick tour of 4 more of these common traps.
First up, we have consult question bias, and honestly, this is just another kind of frame. It's when one doctor asks another for help with a very specific, narrow question, like, how should we treat this problem? And the consulting doctor just answers that question without ever taking a step back to ask, hold on, is this even the right problem to be solving in the first place?
Here is a perfect and pretty dramatic example. A man had brain bleeds. The question everyone was asking was how to manage them. But a new doctor came in and completely reframed the question to why they were happening. That simple shift, just changing the question, led to discovering a spinal fluid leak from his chemo and an intervention that saved his life.
Next up is what's called curbside bias. This is what happens when a doctor just casually asks a colleague for advice in the hallway. You know, on the curbside. It's informal, it's fast, and because of that, it's incredibly risky. You're giving an opinion without seeing the patient, without seeing the full chart, without the full picture.
I mean, think about this. A doctor asks about managing what they call an incidental stroke found on a scan of a patient. A quick curbside answer could be a disaster. Because when the neurologist actually went and saw the patient, they realized that stroke wasn't incidental at all. It was causing life-threatening brain swelling.
Okay, this next one is subtle, but it's so important. Imagine a really common complaint, like confusion in an elderly patient in the hospital. 99 times out of 100, it's something common. That's the noise.
But what about that one time it's actually a stroke? That's the signal. This bias is all about missing that rare but critical signal because you're just so used to hearing all the noise.
So an 83-year-old woman is confused after her surgery. Everyone assumes it's the anesthesia. That's the common noise. But a really observant nurse noticed something. She'd only eaten the food on the right side of her plate. That tiny, tiny clue was the signal that led them to discover a stroke on the right side of her brain.
And finally, there's location bias, where you see a patient can dramatically change how you think about their problem. In the ER, everything feels urgent, acute. In a clinic, you're looking for more long-term, chronic issues. The setting itself creates its own frame. So, a man comes to the ER because he fell. The ER team is, of course, totally focused on the fall, the acute event. They almost missed his chronic foot drop, which he just blew off as an old back problem. It wasn't until a resident spotted some muscle twitches that they reframed the whole case, leading to the devastating, but correct, diagnosis of ALS.
So, if our brains are just wired with all these traps, how do doctors ever get it right? Well, the good news is they actually train to recognize and counteract these biases. It's really about learning to think about how you're thinking.
And what you're looking at here is pretty much their toolkit. For every bias, there's a countermove. To fight Occam's razor, you mentally just erase the patient's main diagnosis and ask, okay, if they didn't have that, what could this be? To fight location bias, you ask yourself, how would I think about this patient if they were in my quiet clinic instead of this chaotic ER? It's a very conscious act of reframing.
But really, these strategies aren't just for doctors. Questioning the initial frame you're given, thinking about how context is shaping your perspective, and always asking, what's the worst-case scenario here? These are powerful tools for literally anyone trying to solve a tough problem.
These neurologists, they spend years learning how to spot and dismantle these mental traps in really high-stakes situations. It really makes you wonder, doesn't it? What kind of frames are shaping our own decisions every single day? And what incredible things might we see if we just took a second to step outside of them?